Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopaedic Principles. Today we have a symposium involving world-renowned shoulder experts. Dr. Paul Sethi from Connecticut, Dr. Raffy Mirzayan from California, and Dr. Joseph Abboud from Rothmans, Philadelphia. I'd like to hand over to Paul for further proceedings. Over to you, Paul.
Thank you so much. Hitesh, thank you again. I'm continuing to be impressed with what Orthopaedic Principles publishes and produces, and your contribution to education is fantastic. Today, we're going to do case-based learning. We're going to just discuss cases and sort of learn through the cases as opposed to just the lecture that we have at you. Our faculty today is the three of us: Dr. Joe Abboud, shoulder and elbow surgeon in Philadelphia, Dr. Raffy Mirzayan in Los Angeles, and this is myself on the right in Greenwich, Connecticut. And you know, there are a lot of things that link all of us together, but as a selfless plug, I want to make sure that you do realize that the plug one for us is that the three of us have come together and created a course, a shoulder course. It's the comprehensive shoulder course for Shoulder 360. This year will be the inaugural course at end April in Miami. Miami is a wonderful international location to travel to. We're going to have about 45 world recognized faculty, and I promise you, and you'll get a flavor of it, this is going to be an exciting experience and course for all of us. So welcome co-chairs Joe Abboud and Raffy Mirzayan.
Thanks, Paul. It's an honor to be here.
So
Thank you, Paul.
Thanks, Joe. Let's just jump right into it. There is no trickery or no tomfoolery. You guys are already the high-end ones. So we're going to just discuss cases and stuff that doesn't allow you to sleep well at night or stuff that really bothers you. We want to take this not from recognition of terror, but from recognition of how I can be a better doctor and a better surgeon. So, you know, look, this is the first case, and he's an 18-year-old male, and he's an American baseball player. So for those of us in Asia, this is like your bowler, right? A thrower. He also plays American football. So he plays a throwing sport and a collision sport. And he has a shoulder dislocation. Rough, just simply, you know, acute first-time dislocation, 18-year-old male playing two sports. Tell me about how you decide whether or not he's going to need an acute operation.
It depends on whether there's bone loss, if they have a big Hill-Sachs lesion, and we know that the younger you are, the higher the likelihood that you're going to have a redislocation. But acutely, no one wants to have surgery. So I send them to physical therapy, get the range of motion back. If within a few weeks their apprehension and relocation signs are gone, and they're not a really intense overhead athlete, I may treat them non-operatively, but I will have a discussion with them and tell them that there's a high likelihood of redislocation.
Joe, in Philadelphia, and this is going to be interesting for our Asian counterparts, do you get a CAT scan or an MRI after the first event?
So I typically, for something like this, will get an MRI, not a CAT scan, because I'm not suspicious of too much bone loss. And I've actually gotten more aggressive in fixing this more acutely after their first episode than waiting. And I can explain that later if you'd like, or now.
I think now is a good time. Thank you for pitching.
Yeah, so my experience, and I've had shoulder instability myself. I can tell you that most of these young men are kind of knuckleheads like me, and they go on to dislocate another 20 times before they get it treated. What ends up happening is you go from having a problem that's solvable in a relatively anatomic way arthroscopically to a problem that has to be sort of patched together and managed, and becomes a lifelong issue for somebody. And so in my experience, when I tell somebody to go away and do therapy, most of them end up coming back and saying they've had another episode of instability at this age. And now they've gone another 6 months since the acute injury. And I don't think in my hands, their result is quite as good as those patients that get it done acutely.
So that brings up a really relevant point, right? As surgeons, I think we are inherently conflicted to tell someone to operate first. And Joe, it's not my remote supposition with you because you articulated why. And we've moved from non-operative treatment of shoulder instability to now the discussion of an early acute treatment. I recall a story that Pat Smith, the University of Missouri football doctor, told me. And he says he's so upset sometimes when he has to repair this athlete's shoulder after the season because there's so much cartilaginous damage. And you're right, you start to wonder if you had done this earlier, if you had sort of maintained your blood pressure, your blood sugar in your 30s as opposed to your 70s, would you have fewer sequelae of that? And I wonder if we're going to slowly get there, but I do believe it's a cultural shift. Raff, how often are you going to press someone into first-time surgery after a single dislocation?
It's usually young patients like this guy, so it does involve a discussion with the parents and the family and the patient. It just depends. If they're an overhead athlete, if they're a contact athlete, their likelihood of redislocating is really high. I'm going to push them really hard. If they're a lineman, for example, and their hands are just always in front of them, and they're not going to go overhead, I'm less likely to operate on them. But I couldn't agree more with Joe, because we do see that the more dislocations you've had, the more damage you have in the joint. And a lot of times it could be irreparable damage, like the cartilage loss that you mentioned, Paul.
So our counterparts on the other side of in Asia and India and all throughout, I think Hitesh has close to 200,000 followers now. They're not going to see patients at their first dislocation as frequently, or just the simple resource is not going to be there to get everyone in that fast. So they're often going to be faced with different issues. But nonetheless, this is a boy, and he was playing two different sports, and he wanted to play at the college level. So he tried to get through the season. He was treated non-operatively, exactly as you suggested. Just a couple of weeks, is when he felt good, when he had protection of himself. Then he went back. Well, he had a second event. He dislocated again. At this point, is brought to the operating room and has surgery. Right. So now here's you're looking through an anterior superior portal down at the anterior aspect of the shoulder. And Raff, there's no tricks here. Right? There's no tricks here. But I want you to say what you like about how his surgery was done, what you don't like, and what would you do differently, because you've got well-qualified surgeons on the horn here who can say, look, I would do that. I would do it differently. Get into some minutia here.
So I think I can't see all the way to the posterior glenoid, but just compared to all the shoulders that I've done, it doesn't look like there's bone loss. So I'm glad that this was done arthroscopically. I would have done the same thing. I do like the fact that there's at least 3 anchors that were used anteriorly. I like that how the anterior band of the IGHL has been properly retensioned. And the most superior anchor is right in that notch where you're at the hemisphere between the northern and southern part of the glenoid. So it's been properly retentioned all the way up to the anatomic location of that anterior labrum. So, and there's a nice little bumper effect as well. And I don't know how much that is a factor or not, but I do try to achieve that as well. It looks like they were I can't see knots. So I'm assuming this was a knotless repair, which is what I do now myself. I don't tie any knots in these in the arthroscopic Bankart repairs. So those are all the comments that I have.
So, Raff, stay with you, and then Joe will go to you in a minute. What about the role of mattress sutures? Do you think mattresses help, don't help?
I've never done it myself, so I can't really tell you from personal experience. I think the way this is done, and this is the way I do it, is good enough. So I don't know if there's an advantage to doing a mattress suture, but what are your thoughts?
So, I think it depends on the quality of the labrum. So sometimes you get into a case and the labrum is so beat up and the tissue isn't bumping up as much as you want it to, or tensioning as much as you want it to. And I don't think you actually need a physical bumper, but you need to be able to stack good tissue. So I will at times alternate a mattress and a simple to get it to really where I want. Or sometimes on the anterior inferior and poor quality tissue, I'll use a double loaded anchor and use one mattress and one simple, like a Mason Allen. Joe, Patrick Denard said at a conference that I was recently at that he is going to do a Hill-Sachs remplissage type procedure in close to 80% of his patients, irrespective of size, pathology. He thinks that there's not very much downside and probably only gravy to that. Can you comment on your role for remplissage, what you think of that comment?
So as far as remplissage, I tend to use it in patients that I'm suspicious that their Hill-Sachs defect based on MRI or CT is significant. And I would say probably significant to me is they don't quite engage, but when I'm examining under anesthesia and arthroscopically, the head seems to be close to engaging with the glenoid. Because if they engage, then I should have been doing a ladder J in my mind. But if they don't engage, but it's a pretty sizable lesion, then I will do a remplissage. I think that helps tether the head a bit to prevent the engagement and external rotation. So I will typically do my remplissage, and I'll do that obviously first, and then I'll do my Bankart.
And that's an important nuance that we can get into later, but addressing the remplissage, or maybe not tying it, but putting the sutures in first will not box you out. Raffy, at the Kerlan-Jobe clinic, I don't recall doing very many posterior inferior sutures to balance out the hammock of the inferior aspect of the IGHL. Has that still remained true for you in California? Do you use posterior inferior sutures in standard anterior stability in football players, or where do you stand?
I've never done one. I don't think it's necessary if you can properly release the torn labrum and retension it anteriorly. I don't think it's necessary, but I've never done one, so I don't have experience with it. And also, I agree exactly with what Joe said as far as remplissage. I don't think you need to do it if there's no Hill-Sachs defect. It just doesn't make sense. And I was initially very skeptical about the remplissage, but worried about loss of motion and stiffness. But I've done many now, and I can tell you it doesn't affect range of motion or doesn't lead to stiffness. So if there is a deep Hill-Sachs lesion, I don't hesitate to do remplissage. With minimal anterior bone loss from the glenoid, I would do remplissage.
All right. Well, we've only gotten one slide in. I better start moving. So look, we talk about follow-up being challenging at times. And as it turns out, it's 6 months after he's playing shortstop and he throws the ball and he feels like he has something happen, but he didn't come fully out, right? He has a new MRI done at that time. And the Hill-Sachs was a little bigger, but the labrum was intact, right? You're not getting the actual images, gentlemen. So is anyone going to bite and tell his kid to have revision surgery at 6 months post-op? He had perhaps a subluxation, but somehow he got something more on his Hill-Sachs. Raff, what do you? This is your case, right? So you got to face this kid versus someone who comes in as a second opinion, which you may treat differently.
So it's interesting. I don't know how you could deepen the Hill-Sachs without an actual dislocation. So if the labrum's intact, I'm going to look for a Hagel to make sure it's not torn from the other end. Because how else is he going to get a deeper Hill-Sachs if he didn't actually redislocate? But if it's just a subluxation episode and he didn't have a true dislocation, I'm not gonna want to operate on him right away. I would try a physical therapy and strengthening first, and then see how he does. So that's my thought.
Denial is definitely part of all of our lives, right? Oh no, you only sublux. You're right, Raff. How did he get a bigger Hill-Sachs and not dislocate? I mean, but the labrum's intact, and you can't always tell how good the labrum is on an MRI. So anyway, he didn't have surgery, and 3 months later, you get a call from the emergency room, and there he is. Right. So look, I think the point on that one is that, look, when a guy has a problem, he has a problem. You just have to recognize whether, especially when it's your own case. If he'd come in as a second opinion, you'd say to him, Raff, I bet, look, how do you get a bigger effect? So when the call comes in, I have the office say that I am out of town. He's back in the office. He feels loose with his ADLs. He getting out of bed has an event. He's like, look, I can't play sports, and I have a possibility to play not Division I, but Division III football and baseball. I'm a good enough athlete in both of these sports. Here we go. This time you have to get your own MRI scan. And as you look through the MRI, coming down axially, Raff, comments?
So it doesn't look like he's got a very deep Hill Sachs, but he's definitely got a Bankart. There doesn't appear to be any bone loss anteriorly in the glenoid.
So, Joe, I'm just going to make it easy because sometimes the images don't show across well. The middle image is demonstrating that he has no Hegel, okay? And then I want you to be critical. Here now you get a chance to see where your 3 anchors were placed for your Bankart repair. And Raffy didn't allow us to do a posterior inferior suture anchor, and this is why the guy failed. I don't know why Raffy wouldn't do it in this case. But Joe, what do you think of those? Can you see those 3 anchor plate positions?
Yeah, I mean, depending on the cut, I mean, I think they actually look pretty good. I don't use the posterior inferior anchor either, to be honest. I know a lot of people talk about it, including Tony Romeo, but I've not been a user of it. So, and you know, those pictures look fantastic as far as the tensioning of the tissue. So if this guy had instability again, I also worry about, does he have some ligamentous laxity? I don't think it doesn't look like a technical issue to me from what I'm seeing on the MRI. And the other thing important to see here is that, you know, even though you have these anchors here, you do not get a postage stamp defect in the bone after the dislocation. So he didn't get a bony Bankart.
So Joe, now I'm going to move you up because you're going to demand a CAT scan, right? It's a revision surgery. You're going to demand a CAT scan. Does your CAT scan add much for you with this case?
I think the Hill Sachs looks a little deeper on the CAT scan to me, on that left image than it did on the MRI.
Mm-hmm.
And he's got a little bit of blunting of the glenoid rim on the axial cut up top.
Bone loss measurements are done at 3% on this kid. Raff, coming back to you. So now he is a baseball player, okay? He also likes to play football and is a receiver. So guys in Asia, he's like a bowler. He wants range of motion. He's had what we would consider a reasonably done arthroscopic procedure. He's failed relatively quickly. He now has events where he feels unstable with ADLs. So it's not just sort of positional or sport intensive laxity or instability, more appropriately. Raff, what do you do for him?
So I think the history, like you said, that it comes out at night in bed, that really worries me. That tells me it's significant, and it is not just in the apprehension position. There's not a lot of bone loss in the anterior glenoid. So for sure he needs surgery. There's no question. So at this point, arthroscopically, I'm going to assess the tissues. Are they good enough? Are they going to hold suture? Am I going to be able to repair the capsule and the labrum and retension it properly? And if so, I would definitely do a remplissage on him because the Hill Sachs does look deeper now on the CT. But I mean, my concern is he's already failed 1 surgery at this point. If I'm going to do 1 surgery and be done with it, so there's no chance of, or a very low chance of redislocation, I would do a ladder J and just tell him that I mean, yeah, there's definitely risk of loss of external rotation, but you know, again, I would have a discussion with them, but I tell them if you want 1 surgery and be done with it and have the lowest chance of redislocation, I would do a ladder J on him.
So
the other thing is,
doctor in Los Angeles is, doctor, we'll do whatever you say. Which operation? What should I do? Revision scope or ladder J?
I would assess the tissues. If the tissues are amenable to repair, I would do an arthroscopic repair with the ladder J.
The doctor in Philadelphia, how do you weigh in on this case?
So you did the index operation and you felt like it went well?
Yes.
Then, you know, I think that in this situation, I wouldn't repeat the same thing. I would do a ladder J then.
So ladder J. Guys, I'm sorry. Hello? Yes, Anand, I'm doing a conference call. No, I can't talk now. What? You're watching the conference. Yes, Anand. No, Raffy is trained. He did a fellowship at Curlin. Yes. No, Joe didn't do a Columbia Fellowship either. Guys, I'm sorry. It's Anand Murthy. He's calling in about this case. So
What would
Let
he
me
do?
guess. He wants to do an open capsular shift.
Yeah.
Anand, it's uncomfortable. Guys, he's concerned that neither of you had a Columbia Fellowship and don't know about an open caps. Yes. Okay. Well, I'm sorry. Listen, we're on a conference. I'm sorry, sir. Yes. Okay. Murthy wanted you to do an open shift. What do you say, Joe?
I think it's definitely a viable option. And the thing about an open shift is I do it so rarely anymore that in my practice, I have more predictable results doing a ladder J. I'm more comfortable with it. I do it more often than doing an open capsular shift. But I think you can make the argument, and he trained with Bigliani on it. He does a very good job at it. I think it's a good option.
All right. So going forward, I decided to give you a little information. Do you think the examination under anesthesia matters? So let's show you. This is the same case.
Live on. Yep.
Out, in, out. So this is a grade 3, at least to me, in. I'm always going Raffy first, so let's stay with that, and Joe first.
I think if he locks, if he's got an engaging Hill-Sachs lesion, then I would definitely want to do a ladder J at that point. But it doesn't look like it's locking to me, so it just stays out and he comes back in.
How's that not locking? Grade 3 is 3. Is that like a Mirzayan 3+, or I don't understand?
But it reduced very easily to me. I don't know. I mean, if you feel like it was locking, then I'm gonna do more ladder J. I'm gonna lean towards ladder J.
Joe, you got voice coming through there, buddy? I think you're muted.
Yeah. So when I do an examination under anesthesia, most of these cases, I assume here you're going to do something open, but most of my cases are lateral cubitus. So I bring the arm into abduction, and I just gently kind of extend the arm a bit, and then sort of try to sublux the arm forward and backward. And the patients that are extremely lax at grade 3s that are dislocating, they'll just slip right out without any force at all. And those concern me if I'm going to do something arthroscopic, because the forces on that repair are going to be tremendous versus the ones that kind of sublux, grade 2 or grade 1, where they sublux a bit, but they don't get a Mirzayan 3+. So, those, but I don't, I think it's a very helpful exam. I think it's definitely helpful exam under anesthesia.
That's the paper I want to write. That's probably something I'd like to try and figure out moving forward. I think we're going to call it the Mirzayan 3+ is going to be an indicator that a standard open repair is insufficient. Now, there's so much nuance into what is a standard anterior repair, and I don't want to get into rabbit holes. So anyway, we're going to continue to give you a little information on this case because I feel like you guys aren't that smart, and I want to give you as much as possible. Raffy, you told me you wanted to see if he had robust tissue. Here you are looking around his shoulder. There's his Hill-Sachs. There's his labrum. You're looking down the labrum. Don't ask for more. Don't ask for probing. Robust enough, yes or no?
From what I see, no. But I mean, when I assess it, I actually grab the tissue and lift it up and look at it. It's not just the initial visualization that you're giving me, but based on what I'm seeing, I'm going to say no, it's not good enough.
All right. Version 2, there's his Hill-Sachs. Joe, you astutely pointed out that it was a little bigger on the CAT scan than you appreciated on the MRI scan. And, what is an engaging versus a non-engaging Hill-Sachs? What arm position is it before or after repair? I think, people can get really sort of excited about this discussion, but we classify that as a Mirzayan 3 Hill-Sachs over here in Connecticut, just the same. Any commentary for you on the Hill-Sachs, Joe?
Yeah, I'm very concerned about the size of the Hill-Sachs. It looks like it engages. So, for me, this is an open procedure. I hope I'm not lateral decubitus.
So
100%. After after the second arthroscopic video that you showed, Paul, for sure, I would do open. Yeah, no question.
So this boy to me, I think it's interesting, right? You kind of smelled, or I saw where you guys are going to go right away with the choice of latter J, but it's revision surgery. It is so it's revision surgery in the setting of no bone loss in a thrower that we choose a latter J, which to me is, I think not so straightforward. So that's what it did.
Agreed. Agreed.
Very concerned about his range of motion. So I did not do a capsular repair. The other thing that I did not do that I would have considered doing in some other people is an additional remplissage or something on the back of that Hill-Sachs lesion, because I was worried, that I'm going to further, even though it doesn't restrict my range of motion a lot, I've already done a little bit of range of motion restriction. I'm careful not to get into the middle. So anything different you guys do in an open operation for someone who's going to be an overhead athlete?
No, but Paul, why would you do a remplissage on top of the latter J? How? I mean, what I'm asking is with the latter J, you're going to get the sling effect. Your Hill-Sachs is never going to engage the anterior glenoid, especially when you're adding the bone block there. So what's the rationale behind doing the remplissage in addition to the latter J?
I think there's more to it than that, right? Because if we look at latter J's, there's still about an 8% incidence of recurrent instability subluxation, right? So then you go back to, okay, well, what am I doing in the latter J? I'm trying to take this from an on-track, or rather an off-track, to an on-track lesion. Do you really, in all situations with a 7mm graft, do you change it to being back on track? And I don't know that you necessarily change it to being back on track all the time. So I think it is possible for that articular cartilage loss to still engage. It'll engage with neoglenoid, but it'll still engage, and the people can feel that, right? They can get the sensation that they're falling into something, and they get some pseudo subluxation sensation as that bony fragment sort of enters their articular surface. And this kid, as it turns out, had pain in the back of his shoulder for a few months as he got back into throwing. So for me, and Raff, you can comment on my sort of mental deviations, and Joe too, there is some role for bipolar fixation and addressing that, and that's not necessarily with allograft in all cases.
Is that your bipolar mood disorder, or is that the patient's bipolar lesion on the shoulder?
The answer to the question is yes. All right, so let's keep going on this one. I can't let this case end. Return to play criteria, Raff. Return to play criteria for this guy with a latter J. How long? What do you want?
Well, I want my bone, the coracoid, to heal to the glenoid, and that typically happens at about 3 to 4 months. And for patients with latter J's, recover a lot faster than an arthroscopic Bankart in my hands, and they tend to they don't stiffen up as much compared to arthroscopic repairs. If it's a higher level athlete, I tend to get a CT scan to see if it's healed. Although
CT scan, you get the CT scan. Oh my gosh, radiate
yes, sir.
those poor young males.
Well, it's low dose radiation, and but what's scary though, a lot of times you don't see union, or actually sometimes the bone is dissolved, and you're like, well, what's holding everything up? Is it just a fibrous union? But clinically, they're doing well, they're stable, they have good range of motion, and they want to return to play. So for latter J's, it's usually between 4 and 6 months is when I let them play.
Joe, number of months, and then yes or no to CT scan, because I want to move through this case.
So I don't typically get a CT scan unless I'm clinically concerned about something, because oftentimes it may give you data that you don't want to see, like Raffy said. And then I don't think most players are ready at 4 months, probably 6 months in my hands.
Got it. So I'm going to say no to CTs mostly, and 3 to 4 months, I'm going to let them back. One last point to make. On this MRI cut on the right side, this is using a headless screw system. And this is a case where there was not significant bone loss. You had a latter J for no bone loss, right? What you can really see is that when you don't have bone loss, you really have a very small contact area where the coracoid graft is going to meet the glenoid. And I think you either want to think about this, you want to do a little more aggressive burring, or technically you have to just sort of, it's slightly different because your ability to get healing is so much harder.
Well, the other thing that helps with the other thing that helps the stability here, Paul, is the overhang of the graft onto the glenoid. So it abuts the humeral head nicely.
Joe, I appreciate that. I'm going to have to change your prescription glasses to the ones that can see. All right. Anyway, next case. He did reasonably well. I don't want to tell you he went back and killed it, but he did reasonably well. Next case, this is, in between cases, we're going to have a reminder to look at shoulder 360, where you see these chairmen interact. Here we go. This is an MRI scan, right? It's an MRI scan of a kid who had an obvious dislocation. You can see his Hill sacks. Raff, what about his labrum?
Based on the axial cuts on the left, I don't see a tear actually.
So is this kid cousins with the last patient who had a subluxation or a Hill sacks and no labrum tear? I mean, am I running a special on these in Connecticut?
No, I want to see if he's got a Hagel or not.
So you get in to do the case. As it turns out, I was out of town. This kid is my friend's
You're always out
kid.
of town. Like, who's taking care of your patients, Paul?
Well, my PA, Kevin, who's a superstar, saw this boy, got him an MRI. The dad calls me on my cell because everyone calls me on my cell. In case if you're a patient listening, you can have my cell because call me at midnight, I'll fill your prescriptions. I get into the case, right? I look at the MRI quickly. We're doing the case. He gets teed up and I'm like, there's no freaking tear. Oh no. He has an MRI with instability on it, right? For sure. He feels a little loose under anesthesia. And his dad's like, look, you got to get him in because he's going to play lacrosse at an Ivy League school like everyone in Connecticut does. What am I going to do? So, Raff, you kind of stole my thunder.
Is he, I would think ligamentous laxity. Does he have multi-directional instability? So you can dislocate that way without a Bankart, but I'd like to see the coronal oblique MRI to see if he's got a Hagel, or now that you're in the scope, I would assess the capsule anteriorly.
Yeah. So, interestingly, that's exactly right. When I'm looking at some of these MDI kids, the rotator interval is a little wider and the tissues you kind of get a different look for it. But you know what? Here you go, Raff. Here, you look inside the shoulder, way down low. That's Hagel example A. And I thought I'd just sort of digress instead of just specific patients, sort of looking at a couple different Hagels. And here's another Hagel case that I saw recently too, where I'm coming down and there, you see the fibers of the subscapularis, and then I back up and there's the bigger capsular tear. So this top one is right at the sort of inferior neck, and this lower one that's still playing is going to be more of a traditional anterior Hagel. So does size of the Hagel matter to y'all?
I mean, if it's going around the back, it does.
So how do you fix these? Raff, you go first, and Joe, how do you fix these?
The posterior ones are easier to do arthroscopically, I think, but
so
the anterior ones, I would do open. I would do an open approach to repair this.
So, Joe, you're going to scope first and do it open. You intimated that you like to scope in the lateral, but open in the beach chair. How does this work logistically? Because sometimes you're not sure if it's a significant Hagel or not. How do I sort through that?
Yeah, I've actually never had that situation, but if I did, I probably would reposition the patient because I would either do that or do them floppy lateral, so kind of deflate their beanbag a bit, kind of bring them over kind of floppy lateral, not full lateral. I don't do open approaches to the shoulder in the lateral position. So, I'd want to be optimized position wise to make sure, I'm set up for success. So even if it's painful, I would consider breaking down and re-prepping and draping if I have to.
Raffy, what
Joe,
do you
so
think?
how do you do your ladder J's? If you start with you scope first, then how do you do your ladder J's?
I do my ladder J's beach chair. So if I'm doing
you
a ladder
scope them in
J,
beach chair.
I I pretty much believe the OR is where I exercise my plan. I don't develop my plan in the OR. So unless I got caught my pants down, I'm not going to be doing a scope and then deciding if I'm going to do an arthroscopic procedure or ladder J. I've already decided. So
I see. Yeah. For me, if I'm going to do a ladder J or open procedure, I start in a lateral decube, scope the shoulder, and then deflate the beanbag. And one of the techs in the OR comes and pulls on the draw sheet, and the patient is turned into supine position and put more into a reclined beach chair position. So I routinely do that, so I don't have to re-prep and re-drape. We just have to I just reposition the patient into a supine position to do the open approach.
Raffy, you need to make a video of that.
Okay.
I'm not kidding, because I think that Joe brings up a really fair point, and I agree that the operating room is the place to execute your pre-articulated marching orders. But I think that small Hegels like this can be missed, and if you're a lateral person, then it's very hard to do this in the lateral, for at least for me. So I would love to sort of articulate exactly how that works, and I know you're gonna have to stage something, or maybe make one of your residents go to sleep on the table for a few minutes. but those nuances matter. All right, well, let's keep moving. So look, here, you scope or open. For me personally, and you're going to watch an open video here, every 3 years, I decide to do one arthroscopically. And by the end of the case, my blood pressure is up, my anxiety is up, because it's so hard and so low down, and you're drilling so close, to the axilla, that I don't like it. It's so easy to make a split in the lower third of the subscapularis, peel back, find your capsule layer, and then repair your capsule and your subscap back in 1 or 2 layers. And I think this is a generally rewarding fix that you can get here on Hegel's. Here's just another example of a rugby player with a really chronic Hegel tear. I mean, look at that capsule. It's just thick, beefy capsule. And then going on to do that repair. How common are Hegel's for you guys?
Rare for me. Rare. Like, I haven't seen one in years, but I look for
I think
it.
for every one, for every 10 that are called on an MRI, I think maybe there's one, but they're overcalled on MRI.
So Joe,
particularly MRI with contrast.
Goes back to your point, and here's an MRI I think that is a true Hegel with extravasation of fluid down the neck and sort of this redundant inferior capsule. But if it's called on the MRI scan, are you going to put him in beach chair or lateral? Are you going to overrule the MRI, the radiologist? Like, this gets into the logistics of how you're going to manage that case.
Yeah. So I mean, if there's an associated Bankart tear, then I'm pretty confident that this is a misread by the radiologist. If it's like the previous patient that you showed, then yeah, I'm a little more concerned, and I might do a straight beach chair. Now I've done Labrum's beach chair. That's not a problem. So I can always do a beach chair. I just prefer to do a lateral decube. So if I'm hedging, then I'm going to do beach chair.
Got it. Are Hegel's, forget about the literature, right? In your experience, are they a source of instability? Are they a source of pain, or both?
I think instability, not pain.
Ruff?
Again, I've only seen a handful of these in my career. So they did have pain and instability in most of my cases, but I don't see too many.
Is this, Raffy, a case where you allow him to finish the season? Like, how acute do you have to fix this?
Depends how unstable they are. If they have apprehension and relocation signs, then I'm going to want to be more aggressive in fixing it. If their alignment and their apprehension and relocation signs are gone, then I can hold off.
I think we don't know the answers to these things. I would submit to you that Hegel's can be just plain old painful, just the same. just staying on the Hegels, just really quickly. Now we can look in the back. This is actually a more fun case. The anterior ones can get you really uncomfortable. The posterior ones are pretty straightforward. So when I see these posterior ones, what I'm going to do is I'm going to fix the labrum first, work through the capsular tear. And after the labrum is repaired, then I'll go ahead and grab the capsule and I'll repair the capsule back onto the humerus in that sequence. Any comments on thoughts on that one, guys?
No, I think that's a good plan. Your post-op images look really good.
So, and a combined posterior labrum or posterior Hegel tear is not nearly the same level of stress or anxiety. And I think they do reasonably well, and access to the space is pretty good. And you can be all novice.
I just hope he's not a thrower. he's definitely going to get stiff back there.
He was thrower. Okay. Let's do one more case, staying on unusual instability, and again trying to stay with Hitesh's orthopedic principles here that we can really sort of hone in on. High school football player. He had in-season dislocation. You can see a trend. Has a repeat dislocation, right? And Dad says to me, "Why don't you do a Bristow on this guy? He just had two." And I kind of say, I'm like, oh, well, we don't really do Bristows primarily anymore. And I know, Raffy, you train with Dr. Taboni and you learn Bristows. But I said, no, you don't need that. And this is a case done about 10 years ago. So pardon some of the suture material. But as you look in the shoulder, you get a more global sort of panoramic sense of what's going on. So he didn't have a huge labrum tear. So he was a multi-directional kid with a small labral tear anteriorly. And back then, this was the first iteration of knotless anchors. This is before we had those special cutters that cut it flush. You can see it's still with fiber wire even before tapes, right? So I took, it's a multi-directional case that I did. And again, I think in today's world, I probably would have used tapes. Clearly, I wouldn't have been as long in the tail on those. But I think that I put 3 anchors up the front and 2 up the back, and that's a reasonable formula for me. Now we have smaller anchors. It might be 4 and 3. Anything majorly different, Raff? And give me the venue of 10, 12 years ago.
No, I think that looks great. I did similar surgeries as well. I did 3 anchors in the front, 3 anchors in the back. You really nicely balanced and tightened up the hammock inferiorly. The only thing is post-op, I just really want to keep them in a sling for a long time, let them stiffen up. These MDI patients tend to loosen over time. So I want them to get as stiff as possible after surgery. But I like what you did here. It looks good.
So I liked what I did too. Dad's like, oh my gosh, I'm so glad you didn't do a Bristow. Modern surgery, so much better. And then Abboud ruined the day. So you mentioned this word before. You mentioned this before. Why did you jinx us?
Why did I jinx you?
Yeah, you said post-stem fracture earlier in the talk.
Yeah, this post-stem fracture. Yeah, nice one. Good job.
I mean, look at how nice those anchors were. I got about 80 anchors in a short distance on that image on the left. There's another post-stem fracture I had on the right. So, Raffy, how do you avoid these?
I think nowadays with smaller anchors or all suture anchors, it's less likely to happen. Potentially spacing out the anchors more so they're not very close to one another. But now the dad gets his wish. You can do the Bristow now because it's there is bone loss anteriorly. But yeah. So
I think the premise of this slide is to bring out the points you made. I think smaller anchors, these were, I think at the time, 3.0 anchors. I try not to use biocomposite anchors. I want a more inert anchor in the glenoid. I like the curved guides because the curved guides allow you to be slightly more perpendicular to the glenoid. And Raff, I didn't really do trans-subscap portals until you told me you sometimes put an anchor in trans-subscap to get really perpendicular. Do you still do that?
Every case, yeah, I do.
I think that's important. I think that's important, right? Because we want to see we want to see that we're getting perpendicular as opposed to making, you know, do you remember dome osteotomies? In Blount's disease, you would sort of create drill holes. That's what you've done. That's what I did here, like, you know. So anyway, Joe, are you going to repair this piece of bone? You're going to just open and put this thing back on?
This looks pretty small. So, you know, I think I would.
You hear that a lot? You hear that a lot?
Yeah. Yeah. So I would create like a sandwich here. So I would do a ladder J and move the piece a little bit to place it more anatomically and place it on top of it and create, you know, a glenoid sandwich.
Dead bone.
Dead bones. Yeah.
Raffy, do you like that idea of interposing that bone in there because you need size?
No, I think the ladder J alone would be sufficient. Sorry to disagree with you, Joe, but I would just excise that bone and put the ladder J on the glenoid.
All right, so Raff, I'm going to play this video. Let me get through it. I want you to sort of comment on some of the key features of what you think is good for ladder J, not on exposure. There's a coracoid bone block. How long does it have to be?
I go for about between 20 and 25 millimeters of bone. You know, I think Bristow and ladders are basically the same thing. You just have a smaller bone block and you have one screw instead of two. Ideally, I want to do the ladder J and have two screws for better fixation. So you want it to be about 20 to 25 millimeters long.
I think I fully agree with the length. One of the things that I've learned is I want to try and get that bone to be about the same size as my defect, because I think you see less resorption, right? I mean, Wolff's law is going to tell you if you put a huge graft in there, some of it's going to resorb and then the screw heads can toggle. So if I don't have a ton of bone loss, I'll shave it down to 6-7 millimeters. If I have to get 8-9 millimeters, then I'll use all of it. But here I am creating two drill holes in it, cleaning these out. And then I'll reach in. I'm going to do I'm a subscap splitter. I think you can take down the top edge. If you don't do a lot of these, take down the top third and repair it that way if you do them. The other thing I've learned now is I can stay much more medial. I really don't need to be in the tendinous portion of the subscapularis. It's really a muscular split. Let's see if I can move it along. There, Fukuda in. You can see the Steinman pin sitting above north on the joint, which really helps. You can use these guides. I tend not to use the forked guide. I use a freehand guide on my finger just a little bit more. And there, Joe's your interposed piece that didn't want to stay in the joint. We took it out in this case, and I set this piece in. And I think this can be a little bit of work. And sometimes the retractor medially can get in the way. But you really want this ribbon retractor sometimes can fight you. You want to make sure you don't overhang, like Joe pointed out here. And then I will only use solid screws. And I didn't use a washer in this case, but I tend to use a washer too. Raff, Joe, comments on solid screws, washers?
So I've generally used 4/0 cannulated screws with a washer. However, I did jinx myself because I was on a conference a couple months ago. And of course, somebody that I knew that I did a ladder J on, the screw broke. So I'm going to rethink that. But I think it's probably better to use a solid screw, not a cannulated screw.
I feel pretty strongly about that.
I've used cannulated screws.
Those are titanium screws though, right?
These are screws that I do not use anymore.
Okay, so because I don't use titanium, that's one thing I don't use for ladder J's.
Yeah, Raff, you were saying something.
Yeah, I've used cannulated screws my whole career. I've never seen one break. I know it's been reported, but I don't see it. And I use that.
Wait till next week. Wait till next week.
I know, probably. I just jinxed myself. But I do use that wedge profile plate that Arthrex makes. I think it's nice to have that. It distributes the forces evenly all over the bone block instead of just where the screws are. So I do use that on every case.
I'm a big fan of a washer plate that can sort of distribute. Now, the other thing that I don't do so much is here I've got a nice piece of CA ligament, right? And that's to attach the capsule back onto where I'm going to do this. I find that piece of CA ligament really obscures my view, and I don't know that I can get as flush and as even all the time. So I really have minimized or peeled back the CA ligament or the size of the CA ligament that I use. And I don't want to deviate from the masters, but I do think that this can be sometimes make the surgery harder to be exactly precise on. I'd love your comments on that.
Yeah, I don't do that. I if I can, if there's enough good quality capsule left, I do repair it to the native glenoid. So I essentially make that bone block extra articular, and the capsule provides like a soft tissue interposition between the head and that coracoid fragment. So there's no cartilage to bone contact. So I don't suture.
You're putting an anchor there?
Yes, I put an, now in this case, he's already had holes, or he's already had anchors, so I'd be more concerned. But if it was a primary Latarjet, I would put anchors into the native glenoid and suture the capsule to the native glenoid and leave the coracoid extra articular.
Got it.
I actually am the complete opposite. I don't fix I don't fix the capsule. So once I put my Latarjet at all, boom, done.
Okay.
I think between the bone block and the hammock effect, they're not unstable. I don't think it's I mean, you know, as long as it's not overhanging like Sethi's last case, I don't think it's a source of bony impingement on the head and arthritis. So I have not done it. And I've actually had the privilege of scrubbing with Joe Walsh doing one of these. And he did do it, but I still don't see the value of it, to be honest.
So you hang on a second. You scrubbed with him. He taught you how to do it, and then you have defied the master.
A little bit, because I didn't make a lot of sense to me. It was just a lot of extra work for not very much gain. I mean, I can't imagine the frustration of.
You call me bipolar, and you don't listen to your teacher. Sus. All right. When is there too much bone loss for a Latarjet?
I think when you're getting closer to like the 40, or I just had a patient in my clinic, he's got 50% of his anterior glenoid is gone. So I don't think a Latarjet is going to be enough for that. And he's very young, he's 22. So we can talk about some of the other options down the list there. But I think when you're getting closer to like greater than 30%, I would say is too much bone loss.
30. So you went from 50 to 40. Now you're resting it. The doctor in Los Angeles rests at 30.
30, 35. How's that?
Joe?
I mean, I think that it's not an absolute measurement. It's a relative measurement between the size of the glenoid bone loss and the hill sacks. So I think if it's, you know, in the 40% range of large hill sacks, then it's not going to be, I don't believe it's going to be a good Latarjet.
I think those are really good numbers. I would submit to you that you can measure your expected bone loss on your CAT scan. You can measure the size of your coracoid. And if you can't reestablish 100% of your expected size of bone, then as opposed to a number, you can actually use the patient-specific anatomy to see that you're restoring that back to the adequate size. Last question. When do you need to do something on the humeral side, whether that is a remplissage or whether it's a bone graft to the Hill-Sachs lesion? Raff, then Joe.
Well, if there's a significant bone loss, like we said, you know, like this kid that I have who has 50% bone loss, I'm actually he doesn't have a big Hill-Sachs, but I'm going to scope him first, diagnostic arthroscopy, to see if he's got any cartilage loss on the humeral side. And then I'm planning on definitely doing a distal tibial allograft on him. And then depending on what I see on the arthroscopy, if he has cartilage loss on the humeral side, then I will plan to graft that as well. So, and if on the other side, if I'm planning on doing a distal tibial allograft and there's a significant Hill-Sachs, I will also do an osteochondral allograft for the Hill-Sachs. Got it.
Joe, anything different? Final words?
I think that essentially if there's reconstructible glenoid bone loss, then in the words of Joe Walsh, there's not a Hill-Sachs big enough that a Latarjet won't work for. So I kind of believe that, but I think you don't have those situations. Meaning if you have a huge Hill-Sachs and you usually have a lot of glenoid bone loss, in those situations, you're going to have to do some sort of combined approach, whether it be a allograft to the humeral head for the defect with a ladder J or DTA. I've been playing around now with the distal radius, but I think you have to think about those things. Or some patients need a hemiarthroplasty.
Oh my gosh, you just went on. That's a great comment to go off the deep end, Joe. I appreciate it. We've now hit the 1 hour mark. Dr. Hitesh.
Paul, can we take a question from the floor?
Of course.
Okay, so someone wants to know, do you think that a fully arthroscopic lethargy is going to be the future for these bone loss surgeries?
Raffy, you're one of the best arthroscopic surgeons I know. What do you say?
You're better, Paul, but I mean, that's the debate right now. I think it is technically a very demanding operation. And if you will, you have to put in the time. If you want to do it, you have to do it in the lab. You have to practice it. You're not going to be good at it until you do probably over 20 or 25 of them. To me, it's just not worth the hassle and the headache. I feel very comfortable doing open shoulder surgery. I was fortunate enough in my fellowship where it was at the cusp of going into arthroscopic shoulder surgery. So I had plenty of exposure. What worries me now is a lot of the younger trainees are seeing hardly any open shoulder surgery. So they're swaying more and more towards arthroscopic. But in my hands, I'm just going to do an open ladder J.
So, Raffy, you still do mini open rotator cuff repair like you were trained to?
No, I do all arthroscopic cuff repairs.
So George Atwell is going to publish his series of looking at 100 open ladder J's versus 100 arthroscopic ladder J's, and so show no increase in complications. So Hitesh, I think that moving forward, when the technology and the ability to get the screws and the screw angles become really repeatable, I suspect that more and more people will do it. It'll be a high level operation. But I think it's going to be a viable alternative. But to the gray hairs, like Dr. Mirzayan, perhaps he will be very successful in doing an awesome non-overhanging Sethi type ladder J.
Okay, thank you. One more question. Do any one of you use an external rotation brace after the first time dislocation? Because there was a lot of hype initially when E.G. Itoi from Japan published about the external rotation brace.
Joe, do you want to comment on that?
Oh, go ahead.
So Raffy, I meant to say, will you comment on that?
Sure.
I do not.
I think. Go ahead, Joe.
All right, let's go to it. Raff, just hit it. Joe said no.
I think it makes absolute sense what IG described to us anatomically. But in his series, the patients were casted, so they had no option of being but in an external rotation position. We just can't, in our patients, we can't cast them for that long. So we put them in an external rotation immobilizer. Well, every single time the patients would come back and they had repositioned the external rotation brace to have their arms in front of them in an internal rotation position. That's just where they want to be. So it's very difficult to keep them in that position. So I just abandoned it. So I don't even try it anymore.
Many of these patients, at least in the United States, are going to be back to sports by 4 weeks. They're not going to wait for that period of immobilization. And although it's a very reasonable idea to reduce the labrum back into place, from a practical standpoint, I have not been able to institute it in my practice.
Do we have anything more to discuss, or shall we wind up the session?
I think, I kept it to an hour, so I wanted to just sort of, not have people fall asleep. So I thank you so much, and Orthopaedic Principles.
Thank you, Paul, Raffy, and Joe, for spending your valuable time, and this is going to benefit a lot of people all over the world. Thank you so much.
Thank you for the opportunity. It's an honor. Thank you.